Want to another party after? No. No.
Yeah. Okay, good morning, everyone. Glad to see you here after last night's party. Looking bright and shiny, everyone. So, welcome to this session on homelessness and harm reduction. I'm Riikka, and this is Johanna. We are chairing this session. We are researchers working in the field of harm reduction, homelessness, and substance abuse services. We are chairing this session, and we have 5 presentations today. Each will give their 10 minutes presentations, and then there is room for 5 minutes discussion after each presentation. And just a couple of words before we start about why we wanted to give this session on homelessness and harm reduction. Well, as you probably know, homelessness is very important context in harm reduction work. A lot of the clients of harm reduction services are homeless. And in Europe, homelessness is on the rise, and it's a very kind of serious problem at the moment. So we believe there is important work to be done with the homeless people and with the harm reduction methods. So this is why we wanted to have this session here, and we have 5 interesting presenters talking about the topic. And do you have anything? Did I forget something? Okay, nothing to add. You don't want to sing? No. Sorry, bad jokes. So we start with Emilia, and she will. Her talk is about. They come from Naples and from Euro NPAD organization, and they are anthropologists and also people who use drugs, and her personal experiences has been very integral to her work. So please, Emilia. And welcome, everyone.
Welcome and good morning to all the braves that are here after the party. Thank you. I'm going to stand up. It should be better for me. Tell me if I'm going too fast with the English and everything. So, this is just a heads up about the place we are speaking of. So this is Italy, and this is the region I work in, Campania, and the city I work in. Both of them are rated as the 3rd in terms of population and the 1st in terms of density. And of course, there is always someone out of these countries, and these are the people we work with, people with no documents or no residence or no working contract. The unit I work with has a very complex name. It's a simple operational department unit. It's a street unit and a drop-in integrated center. This is the van. We are part of the national health system, that it's then the regional health system, then the addiction department. We born in 2005, and it was just from the social cooperative I work with. Then in 2012, the addiction department stepped in, and in 2018, the center we work inside now is totally funded and owned by the National Health Services, and the social cooperative became just the partner. We are 20 26 people, 8 from the national health system, and 18 of us are from the social cooperative. Unfortunately, and I ask you if you know differently, but in Italy it's very difficult to have a working contract as peer. So most of us are social operators. I am a cultural mediator because of my bachelor, but it's a bit more complex than this. We also have a doctor. And it's very important because I don't know if there is another service like ours in Italy. I strongly think no, but please correct me if I'm wrong. We work for homeless people who use drugs and people who use drugs. And of course, working in the streets, we met all the varieties of humanity. So migrant people with or without documents, people from LGBTQIA+ community, sex workers, people with physical or mental disability, and so on. The center is right in front of the central station of Naples, but it's closed from the 2nd of October 2023 for renovation works. And the van also has a regular place in the central station square that is very big, and it makes us more visible for people who use drugs. And it's on maintenance from 25th of October 2024. We had a car, and it's on maintenance from 10 days. So we are almost on foot now. We distribute harm reduction materials for people who inject drugs. We build proximity relationship. We support self-empowering and self-regulation. Thank you. Thank you. So the changings are a lot, as we know, every day nowadays. First of all, there is this new kind of drug use that is intravenous cocaine use, that it's not a problem per se. It's a problem when the drug market changes so fast, and when you don't have drug checking, you don't really know what you're using. And it's a problem also because we cannot distribute more than a certain amount of syringes because of the bureaucracy of the national health system. Also, the services are kind of stuck in the 90s, so in heroin intravenous use, and it's very difficult without professional training and professional formation to keep up. Also, homelessness, as Rika was saying, is growing a lot. We have 4 shelters in Naples. 3 of them are funded by the church. 1 of them is funded by the city. With an estimated population of 2,000 and a half homeless people, we have just 200 spots in dorms. The shelters are not gender specific. They don't accept drug use inside. Sometimes it applies also to OAT program users and to HIV treatment. They don't have the revolving doors system. They also have the blacklist system. So if you're out from the 4 of them, you're out forever from the Naples shelters. They are clearly understaffed because there is no fundings in welfare. The growing of unemployment, it's particularly affecting south of Italy. We have no citizenship income of low threshold. It has a very high criteria. The first of all is the citizenship, that is very difficult to obtain, and or the permit of stay. And I want to focus on the fact that for migrant people, selling drugs is an obstructive condemnation for the permit of stay. So the prohibition is very high, in my opinion. Also, the focus of this presentation is the decline of the public health system, because in part, because we are part of the national health system, so it affects us directly. It also affects the population indirectly. So, in general, in Italy, the national health system is autonomous for every region from 1995, the public one. And these are the criteria to access it. And it's very complex if you don't have citizenship and documents and legal permit of stay. About harm reduction, it entered the essential levels of care in 2017, but just one region implemented it. What that means? It means that you still have the right to have harm reduction services as an essential level of care, but if your region hasn't implemented, it simply doesn't exist. Our region didn't implement it, it's just a particular choice of the addiction department. These are the fundings that became less and less from 90 to nowadays for the public health system, but they became more and more for the private health system. Especially in Campania, I want to focus on that region because it's the first for density population, and our particular health region, because they are not only national, not only regional, they also are scaling down to the local places. Our is the first for density population in Europe. The Naples one is the first in Europe in terms of density. So, sorry, I got distracted. Okay, these are the obvious effects of the less fundings to the public health system, and directly on us, and as I was saying, indirectly. There is a lot of discrimination against people who use drugs. We had to wait 2 years for a surgical operation, like for a person who was coming to our service. He also, as an accident, was having surgery and then was discharged on the street. Now we are living with the consequences of an unprotected discharging. After 1 year, we still have to obtain a diagnosis from the public health system that is keep sending us from a visit to another. This happens with undocumented people, migrants, especially because they don't activate, for example, linguistic and cultural mediation, even if it's already from the public health system. And for the people who use drugs, there are these three main problems and obstacles. Because if you're a junkie, of course you are looking for drugs. It's your fault that you are in the hospital, and you are also on methadone. Why should I give you methadone? This is the kind of mindset we have in Italy, also because in a very prohibitionist context, harm reduction is still considered like, okay, if you really don't want to stop using drugs, you have to at least don't contagion other people with your sickness. This leads to the fact that under the public health system, we don't still have crack pipes, drug checking, supervision for the KIP, professional training in harm reduction on all levels, and we still have to do a lot of advocacy for people who use drugs. Sorry if I was too fast, and thank you.
Thank you, Emilia, for the very interesting presentation. I think we recognize these developments in all of Europe. Any questions to Emilia? We have also time for discussion after the presentations in the end. You mentioned training. Sorry. You. Yeah.
Always ready to ask questions. It's great to have you here. I'm from Warsaw, and yes, I'm from Warsaw. Great to have you at the conference, all of you here. And because I mostly work with service providers for people experiencing homelessness, I wanted to ask you, although you are probably not the person to ask about that, but what do you think on the shelter side, homelessness shelter side? What are the barriers that the staff has which block people who use drugs from the shelter?
First of all, I want to connect to what I think Rika was going to ask me. Training. Harm reduction training doesn't exist in Italy, so it's considered a mission, and the most common figure I've found in the social workers is the savior. I have to save you from using drugs, and every time you fail, there is this whole concept of, for me, concept of relapse. Every time you relapse, you are to blame, you are to punish. In OAT system and in shelters also. Then there is the fear that you are going, I don't know, someone is going after you or with you using drugs, that you're doing illegal stuff, and they are understaffed in the shelters, always because of this, because harm reduction isn't considered something needed, fundamental for working for and with people who use drugs. It's considered a mission. If you want to do social work and you want to do harm reduction, you are the special one. I think this is, but I'm open to other opinions, please.
I think that we can all recognize that as well, that harm reduction is not always considered as proper work. Any other questions before we continue? Yep, maybe in the end of the closing remarks, but yeah, please.
Yes, maybe upload one more time to Emilia. So, our next speaker is Gerasimos Grammatikopoulos. Sorry for pronouncing. But he is a medical doctor and a neurologist. He works as a medical officer of a mobile intervention unit at Okana, which is an NGO situated in Greece and work in the field of harm reduction. And his presentation describes the activities of the organization with respect to homelessness and substance use. So, please. So the slides.
Hello from me, from Greece. We are going to talk about our approach regarding dormitories and day centers for homeless people with substance abuse disorder. Now, I think you all know that homelessness and substance abuse disorder have a reciprocal relation. When you are homeless, you have no social support. You have no access to primary health care. Your food and your sleep are not necessarily granted. They are insecure. And you also live within a context of severe stress. Now, this is correlated to the substance abuse disorder, where your own substance abuse disorder causes failing social networks, financial struggles, perhaps even unemployment, and last but not least, mental health issues. So you see how these two categories are actually almost one. In Greece, we have an alarming situation. In Athens, only in Athens, we have about 15,000 homeless people, mostly male, and most of them are there in Athens, but smaller but noticeable numbers are also present in other cities. I'm from Patras, for example. There is not this kind of size, but it is noticeable, and it's increasing. So that's why it's alarming. Half of them are not Greek citizens. That means further social barriers. Okay? It's one thing if if it's a person who uses drugs. It's another thing if he is an immigrant who uses drugs. 60% of them are abusing alcohol or other substances. And now, other substances means a lot of things. Given the bleak socioeconomic situation they live in, we are talking about cheap synthetic stimulants mostly, what's called shisha in the jargon. It's actually crystal methamphetamine of very low quality. 2/3 of them are present comorbidity of physical and or mental health issues, which is actually to be expected. So, our response was a nationwide network in the mentality of harm reduction. How? We opened up a short-term dormitory in Athens, an open day center in Athens, plus 5 more short-term accommodation and day center combination institutions across the country. And of course, the philosophy was that of harm reduction. That means low threshold. That means direct assistance. Okay? What are the axes of the intervention? First one, the physical and mental health of these people. A second one, hygiene and nutrition, because this is not a given for these people. And last but not least, social welfare and psychosocial integration, which is what we actually really need to do in the end. That's the final target in the harm reduction context. But it's not the end of the journey for these people. Now, regarding primary health care, we have medical personnel, nurses, and specially trained personnel that are not doctors or nurses, but are also trained for first aid, overdose, reactions. Okay? Health counseling, we give some counseling for people. We provide psychiatric follow-up and treatment, plus monitoring for infectious diseases and interconnection to the treatment. Now, I'm doing that Emilia said before. If that guy or that girl goes to the health services directly, she or he will probably face a lot of discrimination. Now, it's our job to be the mediators to provide that access. How about hygiene and nutrition? We have trained caregivers that provide meals, nutritional supplementation. We have showers, laundry, clothing. But according to me, the most important one is the last one. Motivational support for a social integration plan. That means to move on, use our services, start reorganizing their lives. We are there to help them. We are there to help them. And the psychosocial integration, which is what I'm talking about. We have social workers and psychologists who provide motivation and guidance over the bureaucratic hurdles. And this is no small job, because, you know, when the system, when a state don't want to have anything to do with you, they have a lot of tools, bureaucratic tools, to make it happen. Now, that's why we are there, helping them, guiding, advising. Special social support allowances that most of these people don't even know they have a right to. We also provide interconnection to services about job finding, about legal issues, and child support services within our institution, within Okana. We provide single or group sessions and a lot of creative group activities so that they feel part of a whole, okay? Now, what's important to me is the right side. It's how you do that kind of thing. Because, again, I'm touching up on what Emilia was talking about. There are no prerequisites or criteria to receive the services. We accept the people as they are. They are people, nothing else. The assistance is direct. Right here, right now. There is no, okay, you have an issue, we will see about that in 10 days' time at around 2 o'clock. No, now. And also, what I'm describing as unsolicited discovery. What that means. You don't wait in your office for that person to come around and say, hey, I'm facing this kind of problem, could you please help? Within the day center, where they're having their coffee, you start talking like you talk to anybody around here. And you discover unsolicitedly their needs, what is actually going on, and how you can be useful to them. Thank you. Another plus is the street work. Why? Because you provide an uninterrupted continuum of the services from the actual street, from the piazza, up to the treatment and beyond. It's all a continuum. It's done by teams which are interdisciplinary. I'm a medical doctor, I'm a street worker. Okay? I have nurses, I have social workers, I have psychologists. And it's not about, oh, I'm a medical doctor, so I don't talk about social issues with these guys. No, no. You have to do everything. We provide harm reduction services directly on the field, which means hygiene, which means tools and stuff for the drug use. Okay? We provide motivation and direct interconnection with the day centers. So we actually escort them, if it's needed, back to the day center. And we provide this continuum. Now, I know I'm preaching to the choir here. Of course, harm reduction works. But we have the numbers. Now, the political issues are changing. Okay? Now, 10 years back from now, it was about morally correct. It was about humanity. It was about convictions. But now we also have the hard data about it. Okay? Now I will just stand on 111 overdose reversals within the day centers. That means about 50 dead people that are not dead. Okay? Within 12 months. How do you feel about it? I feel great. Now, this is work. This is job. My job, and I'm proud of it. Thank you.
Okay, thank you very much, Gerasimos, for this important presentation. And now we have some time for questions or comments. Who would like to start? Well, okay, I would like to start. Because you told that half of homeless people are non-Greek citizens. So where do these people come from, and what kind of rights do they have to access needed public health and social care services, and do they have like similar rights than Greek citizens?
Now, that's the issue. Yeah. I mean, most of them are from Asia, like Afghanistan, deep Asia. So it's also a cultural barrier. They probably have no legal papers, or they are in the process of obtaining refugee status, which is a very long time taking situation, you know, with many hurdles and bureaucratic issues. They actually are almost non-existent regarding the health services. They don't exist. Huh? I don't know you. You can't enter. That's why we are the ones that make this bridging, this interconnection.
Yes.
Because we have no criteria. I don't care if you are illegal immigrant or if you are legal, if you are a refugee. For me, it's not important.
Yeah, it's important that people get needed help. Yeah, all
Obviously.
people. Yeah. Okay. So is that like the biggest problem in Greece when it comes to homelessness, or what are the main reasons causing homelessness?
The reasons are always the same across Europe, no? It's poverty, destitution, drug abuse disorder is also a driving force in that one, obviously, because you lose your job and then you can't go back. Okay, so it's a spiraling down situation.
So there can be many reasons at the same time too. Yeah. So any other questions? Yeah. Well, this is a big room.
Thank you for your presentations. I wonder if you can elaborate a little more about the treatment. You said that you also provide treatment.
About treatment about what?
The drug use and the homelessness.
Okay, now, we provide directly treatment for psychiatric disorders or, let's say, first grade of health treatment about physical problems. Now, if you need specialized support, specialized treatment, like, let's say, you suffer from hepatitis C, okay? We do the referral and you start receiving the treatment directly. You don't have to fight your way hurdle after hurdle after hurdle. That's what I'm talking about, referring to the treatment places. Okay?
Yeah.
Hello. Thanks
Hi.
for your kind of presentation and the other also. Just one question that I don't understand in the work. What's the numbers of the people that you receive in your temporary shelters? I don't see the numbers. How many capacity you have to receive persons? 100 in your temporary shelters?
Okay, one shelter in Athens is 85 beds. Another one in Patras is 24. There are more in Athens. And what actually is important, let's say, it's not about the capacity, it's about how many actually are occupied. And the actual number for the last 12 months is 38,000 plus night person spent in safety. I mean, night person as man hour, you know the idea. Yeah. 38,000 plus night persons spent in safety. So I think it's rather important.
Okay, thank you. Anyone else? Okay. If not, maybe we can move on. Thank you so much.
Okay, next we have Annika Apfel from the Netherlands. Annika works at AMOC, which runs a shelter for homeless European citizens in Amsterdam. And in this presentation, she'll be sharing information about this facility and also the policy environment and community surrounding it. So, please.
Good morning, everyone. My name is Annika Apfel. I'm the location manager of AMOC. We are a center, drop-in center. We have a drug consumption room, night shelter, and social work for people who come from outside the Netherlands, from the EU, and who live on the streets in Amsterdam. I included some pictures. The first, I didn't do that. Okay, do I do that, or did you do that? Okay, yeah, thank you. First of all, a small introduction to what is an integrated service, in the sense of what kind of drug consumption room models do we exist. There's standalone drug consumption rooms, that is simply a drug consumption room without drop-in center or other facilities for homeless people. Mobile drug consumption rooms are probably quite known. Housing with DCRs, or DCR stands for drug consumption room, that is long-time shelter for homeless people that also have a DCR within the shelter. And integrated, I will introduce to you today, that is that is a shelter that includes different facilities that are all in terms of harm reduction beneficial for our clients. And here I present to you Amok. Amok has in its basement emergency night shelter, and during cold winter nights we also have winter shelter. That is 10 emergency night beds and 10 winter shelter beds. On the first floor we have a drop-in center and social work. And on the second floor is the drug consumption room, and our ethic is advocacy and research, which is Correlation, who are hosting this wonderful event. And of course we work together with external partners such as other social medical partners and political partners. I've included a few pictures, to show you how it looks like. The left side picture is the drop-in center, and on the right side you see our night shelter. And of course we have this facility has shared goals from the drop. Oh, yeah, thank you. I have to also click that one. Thank you. Yeah, now it works. So the shared goals of the drop-in center, social work, DCR, and night shelter are, of course, to connect people with the help systems, to refer people to other social work organizations or doctors, mental health care, and other harm reduction services. We are also working towards creating a safer neighborhood. Our neighbors know how to find us. We have monthly or bi-monthly meetings with the neighborhood where also police is present, and other important partners in the neighborhood to kind of compare experienced realities of our neighbors with ours, and to discuss what are the problems that our neighbors experience, and how can we work towards creating a safer neighborhood for everyone. That's important for our clients and also for our neighbors. To tackle loneliness, which is a very important topic, since a lot of our clients are struggling with loneliness. So community building is an important part of our work. And of course, to offer a space to rest during the night, but also during the day. A quiet place where people can just rest. Let's see if this works. Nope. Yeah. Again, two pictures on the left-hand side. You see people lining up in the morning to come inside, and on the right-hand side our drug consumption room, of which I will say a few words more now, because what are the more specific goals of the drug consumption room is, of course, to reduce the number of fatal drug overdoses, reduce the spread of infectious diseases, and decrease nuisance and criminality in our neighborhoods. And there has been a new research published by the university, the Vrije Universiteit Amsterdam, which found out that the criminality in the neighborhood decreases by 25% if there is a drug consumption room. Like when a drug consumption room opens, the criminality decreases by 24%. I think that's quite a fantastic proof of how important our work is also for the people living close to a DCR. And here again, yeah, you see them all. Here again, 2 pictures of our DCR. As you see, it is. It doesn't look as clinical as other places. We prioritize hygiene, and at the same time, we also find community building extremely important. So our drug consumption room really enhances that people are sitting together at the table, that they communicate with each other. Social workers or other people working in AMOC can join and to sit at the table and talk to the clients while they're using. That's extremely important in our work. Oh. Wait. Yes. Okay. So a few harm reduction interventions to mention. I also want to mention things like healthy foods, fun and educational activities, and activation of clients, because all these things reduce stress in the lives of our clients, which means, and less stress means healthier living. So, oh. I don't know how that happens all the time. Okay. And less stress means healthier lives, and healthier lives means healthier drug consumption and healthier, just overall better mental health and physical health. So all our interventions are working towards giving our clients the healthiest and best life we can, I guess. It's jumping here and there, and I see 3 different slides, but let's see what you're seeing. Yeah, okay. These are 2 pictures. One is from our winter shelter. When the temperature drops below 0 degrees, we have 10 extra beds, and then we hang out a flag in front of the house so that our clients can see that tonight. Oh, 2 minutes. Okay, time is flying when you're having fun, I guess. Oh, okay. Maybe something about our principles of AMOC and also especially the drug consumption room. We wanted to work towards having more positive messages towards our clients instead of having messages, don't do that, don't do this. So we are working with 3 ground rules or 3 ground principles, which is safety, hygiene, stress-free. And everything that is against those principles, we tell clients it's not possible here, and that can be anything from, for instance, someone coming inside and with loud music. We say this brings stress to our clients, so we don't want to bring stress, so please put down the music. If someone comes in and starts clipping their nails on the table, we say, this is a hygienic place, please don't do this here, please do it on the floor or somewhere else. So about the principle of hygiene, if someone comes inside and puts a knife on the table, we say that brings an unsafe environment in AMOC, so please don't do that. So everything is based on these 3 ground rules. There was a question in this beautiful conference app about the legal framework. So the possession of drugs is a criminal offense, but the police and prosecution don't intervene if there's no indication of intent to supply. So as long as they think that you're not dealing with drugs, you won't be prosecuted. We also have a letter that we can give to clients that says that they are a client of a DCR. So that if they get checked on the streets by police, that they can say, this is where I'm heading to. And they know that they're within the care system. I only have 2 minutes left. I can say something very short about the partner organizations. Someone really wants me to hurry up. Something about the partner organizations that also work with EU citizens who use drugs. And that is within the Regenbooggroep, our street work team, Doppere 020. T6, which is a facility where people can stay 3 months or longer if they need more long-term care, as for instance for addiction care or mental health care. Amok West is our intake location, and of course Correlation European Harm Reduction Network. You can see our building, our beautiful building on this picture. And I all thank you for your attention, and I also want to say harm reduction works. We've never had a fatal overdose in our drug consumption room, and we can be very proud of that. We have around 80 clients inside every day. Yeah, and if you ever want to come visit, we also offer site visits. Just contact me after. Thank you very much.
Thank you, Annika. Maybe it's Stalin's ghost messing around with your...
He doesn't like me.
Yeah. So, any questions to Annika? Yep.
Yes, thank you for your presentation. It was very clear, but always it's a very good job that you do, but I'm always wondering, what about non-EU citizens who come at your door? I think I work also in a drop-in center. It's always a problem if it's not somebody from your target group, but do you have places where you can send them to get similar service?
Of course, yeah. So the Regenbooggroep has 10 drop-ins, 9 in Amsterdam, and 7 of them are for Dutch citizens and undocumented people, and only Amok Zuid and Amok West are for EU citizens, and that is because the legal framework and the possibilities and the things you can do from social work for EU citizens is very different than the rights that Dutch people have. So our team is really trained to help EU citizens. They know all the rights and the laws that apply to them. And in Amok Zuid, we have about 15 languages, like the staff speaks about 15 languages, so we can also assist our clients in the language that they are most comfortable in. So that's why we have this special facility for this special target group.
Okay, thank you.
Thanks.
Any other? Okay, Julia.
Hi, Annika. I didn't know that your activity was so great. What's your experience with the relocation programs? Like, we are an NGO from Poland, and we're very often approached by organizations from Europe that tell us, you know, we have people here, we would like you to take them back and host them in your host country. So what's your experience with this?
Yeah, our social workers, they can help with what we call repatriation. So helping clients to go back to the country that they have more rights. And we do that if clients want that. Yeah, exactly. See the exclamation marks. Like, if we do that, if clients wish to do that, if they have a better support system in another country, that doesn't always have to be the country that they have a passport from. It can also be if they have, I don't know, an uncle somewhere else that can support them, or if they have simply a better support system. So we don't want to push people, of course, to go back, because we all know if we are trying to push someone, they're not gonna do it. So yeah, but we can also help with that. Yeah, and we have a lot of clients from Poland as well, and from so I can imagine that you get a lot of requests about that. We have one project that is called Soft Landing, and that is that a social worker can also go together with their clients to the country that they want to go to, or their city, to assure that there is that the person is not just dropped somewhere, that they don't just send them by plane, but that somebody is really landing soft. Yeah, yeah, yeah.
We have to continue, but thank you, Annika.
Thank you all.
Super.
So, our next speaker is Gonzalo Enrique, who is a psychologist who has 20 years of experience of working with homeless people at the health sector in Lisbon. At the moment, he works as a coordinator in emergency shelter in Lisbon, which has, among other things, drugs and alcohol consumption rooms for residents. So, please.
Thank you. Morning to all. Big thank you to the organization for hosting us here. Let's see if I have luck with the presentation. Okay, this is the disclaimer. I'll skip that. So I'm here to present you the Lisbon Municipal Emergency Shelter that operates under the framework of harm reduction. It's 100% funded by the municipality of Lisbon, and it's run and coordinated by two institutions called Ars do Pinhal, my institution, and another institution called Vitae. Ars do Pinhal has a lot of experience since he also runs the low threshold methadone program, the fixed drug consumption room, and Vitae has a lot of experience also in the housing sector, and it's also a new experience when you get two NGOs to run a project. So I have no notes, but let's proceed. The shelter, it's very inclusive. It has the maximum capacity of 128 people. This shelter started during the COVID-19 as an emergency response from the municipality to the pandemic, when we all had to stay inside our houses. The municipality also created an emergency response in Lisbon that you used to use for the cold weather during the winter. It's like a winter shelter for 10 days normally, or 2 weeks maximum. So we all thought that it would be 2 weeks at home, but the COVID pandemic took longer than that, and from one municipal shelter it went to 5 municipal shelters. Our institution was giving support to these shelters, and also Vitae, and we started converging that work into a municipal shelter that had all the important things that we... It's better to use this. Okay, so this is a profile of the residents that we have. People, not, most of them people who use drugs, that have a homeless background, that has mental and physical illness, no linkage to the national health system, and poor labor experience. They're mostly from Portugal, from the Portuguese-speaking African countries, from Europe, South America, and Asia. So, until the end of 23, we attended 701 people. All the shelter has one general practitioner, one doctor that's working once a week, one psychiatrist working once a week, a team of 6 nurses working every day, 365 or 66 per year, 8 educators, in the lack of a better word to translate, it's like psychosocial technicians that work inside the DACR. It's a drug and alcohol consumption room. So we had the experience of running the drug consumption room in this shelter, since the alcohol abuse is has a very strong prevalence in the people that experience homelessness. We also opened up a room for the alcohol consumption. We have 3 case managers of our institution. Every resident there has 2 case managers, 1 case manager of the health side, let's simplify that, and 1 case manager of the other institution that works all the social side. And all people that are staying with us have access to medication, and the work we do with them, it's a work with direct observational treatment, and this makes a big difference. So here are some pictures of the shelter, like the nursery, the rooms, the cafeteria, the activities room, that it's a big part of the work that you do under the framework of harm reduction, and also another education room. So these are the main objectives: to involve residents with addictive behaviors and dependencies for licit or illicit substances in a specific program to raise awareness and promote safer consumption practices and reduce risks and damage to their physical and mental health. Also to promote public health by helping them to reduce the spread of infectious diseases and reduce the possible harms outside of the shelter. This has a big impact on the community. Per month, more or less, is 3,000 consumptions that are made inside the shelter that are not made in the community, and it's very important to have the involvement also of the municipality to give us support. Sometimes the relationship with the community in the beginning, it has its challenges, like you could imagine. So everyone has access to screening for infectious diseases, hepatitis, HIV, tuberculosis. Like I said, they have weekly GP and psychiatry appointments for all residents. Our main objective is to link everyone to the national health system. Also, everyone that is in treatment, let's say for hepatitis, to stay with us in the shelter until the end of the treatment. That's a big part of what we do. They all have access to prescribed medication with directly observed therapy and follow-up. And they also have access to a free medication that we call an alcohol deprivation syndrome prevention program. It started also during COVID-19, since people who use alcohol who would enter in privation by staying in the shelters and not able to go to the streets. And we gave continuity to that program inside our shelter. It's a free medication that people can start to take. They don't have to stop drinking alcohol, but if they want to reduce, they have access to that therapy in that moment. Like the colleagues were saying, we have to have these tools on the moment to be able to intervene. And they also have the low threshold methadone program inside the shelter. They don't need to go out to mobile units or other institutions to take methadone. Here are some pictures of the DACR. On the left we have the injection room, the smoked room on the middle, and the alcohol room on the right side. They all work in the same zone of the shelter. Here are some numbers of the past years to show you that the number of injected consumptions has started to drop during the years in our experience. The smoke consumptions in the beginning were also a big part of the work that we do, and we're starting to decrease. And here is the reason why that is happening, is because of the profile that the people that we have on our shelter nowadays. The alcohol consumption is starting to go up. Why this is happening? Because we find it more difficult to link people who use alcohol to other responses or housing responses, and they stay with us longer. So that's a big part of the population that we have nowadays. Okay, thank you. Also, some demographic data, like the age of the residents and the gender. Here are some data about the main substances that are used in the drug consumption room, mostly crack cocaine. Here are some numbers of another study that we did on the mental health work. The number of people that were linked to psychiatric consumption, to the GP appointments, that were running, 63% were running under the medication management of the direct observed treatment. Here are some diagnoses, some of the part that we do, and some of the residents that we have lived in the streets for many, many years, but never had a diagnosis. So that's a big part of what you do, also to link people to the services and get the diagnosis. These are the data that we collected. And on the right side, you have the number of people that will link to the low threshold methadone program and to the alcohol protocol, the alcohol deprivation program, and the number of people who are linked to outpatient treatment center. From the people that we link to the outpatient treatment center and to the alcohol program, one of each four join the therapeutic community. It's not the main objective of the work that we do, but we find this data interesting. Some thoughts about this work. Many individuals face both addiction and mental health issues. Their complex needs require integrated support that goes beyond traditional models. To effectively address these challenges, we need an holistic approach. And by recognizing and addressing these mental health issues in this population is key to improving our outcomes. It helps to reduce relapse rates, improve treatment adherence, and ultimately promote more stable living situations. For future projects that could use this model, we think it's very important to create partnerships with local hospitals. Under the framework of our institution, we have also decentralized consultations, for example, for hepatitis, and it's very important to create these links. We also have one day of week that we can take people to the psychiatric consultations outside of the shelter. It's very important to create these links. And we find out that with the right support and resources, shelters can become centers of comprehensive care where mental health services are seamlessly integrated with addiction harm reduction programs, allowing to provide pathways to recovery and reintegration. Part of the work that we do in the shelter, we find it very important. When we open doors, we are preparing the staff for everything that they could expect. We also had the experience of running the DCR, and we found out in 3 years we only had 2 episodes that we had to intervene and provide naloxone to the residents. When we compare that data to the data that we have on the DCR, we find out that this has a really effect on the people that we have inside, because they explore less their limits. They don't have to use everything before they enter the shelter. So this is more safe for them, and this has a protective effect on people. This is a photo of the staff. We're doing some training, and this is part of the work that we do. We are always training, always add external supervised staff, and that's a big part of what we do also. Thank you very much for your attention.
Thank you very much, Gonçalo. Now I think there's time for one or two questions. Do you have anything in mind? Yeah.
Thank you for your presentation. I would like to ask you, I'm really impressed about the alcohol consumption room, and I want to ask you, in the case of an over-limit consumption of alcohol there, what are you doing?
So to explain it, I forgot to explain that people have 30 minutes to use in each of the rooms, also in the alcohol room, and they have a mandatory break of other 30 minutes. Since alcohol is a substance that intoxicates along the day, like I think that was the point of your question, sometimes that that 30 minutes could be longer. For imposition of the team, since people are free to, they can drink inside the shelter. They have cabinets to store their alcohol, but we can't stop them from drinking outside. But normally they spend more time with us. We always offer a non-alcoholic drink during the consumption of an alcoholic drink. We try them to drink only one glass during every consumption, and sometimes that the breaks can be longer if the team thinks that they should lunch or they should get dinner. The consumption room is only closed from 9 a.m. to 10 a.m., from 1 p.m. to 2 p.m. and from 9 p.m. to 10 p.m. for cleaning, and also for people to have breakfast, lunch and dinner. Or involve them in activities. Sometimes that 30 minutes when we are involving them in other activities can be 1 hour or 2 hours, and that's a big part of the things that they introduce during the day with the residents.
Okay, maybe another quick question. We have time.
Yes, can you say what is the annual cost of running the place for 120 people with all the services that you provide? What's the annual cost for the municipality?
Yeah, that was a good question for the municipality, but I think it goes around 1 million euros.
Okay, thank you very much. I think we need to move on, but thanks.
Okay, our last presenter is Esther Aranda. She's a director of harm reduction activities in the organization called ABD in Spain. And her presentation deals with the experience of homeless migrant youth of harm reduction services. Okay, please.
Morning. Thank you everybody for getting up today. This is a very big topic. I decided to not to do a critical about European politicians, about migratory politicians, about the role of Mediterranean countries, about the mental health system in Spain, about the medicalization of suffering in Spain, and about neoliberalism, about capitalism, about racism. No, I'm going to talk about harm reduction and in this specific group of population that is very present now in the big cities in Spain. This is a part of a very big research about the current situation of harm reduction in my country, in Spain. And in the first part of this research, we find out that we have this group, no, the migrant youth homelessness, as a hidden population. So we decided with Marina Sonadellas, that is a migration expert, to explore this situation and to detect how harm reduction can do something. Well, I'm going to do the spoiler of the presentation. Okay, we are going to talk about pregabalina, Lyrica. We are going to talk about ribotril, clonazepam, and we are going to talk about people without rights who is living in the street. Okay, that's the results, and how harm reduction was decided. Very young people. These people arrived to Spain 12, 14 years old and arrived to a homelessness situation at the age of 18, very young. And in the other area, we have benzodiazepinas, gabapentina, pregabalina, prescribed, non-prescribed. That's not the problem because we are the second global country with prevalence of use of benzodiazepinas. Why? I don't know. And we have, and if you see the mortality associated with substance use in Spain, the first one, the top one, is benzodiazepinas. So maybe we have a little problem, no? Because we have mortality arriving, no? A lot of mortality related with migration, a lot of mortality related with the substance use, and very young people using the substances. The last report about the substance use in Spain said that 20% of people before 16 years not migrated. All the people in Spain have been using benzodiazepinas. A lot of people. So a lot of people very young. So we can talk. Yes, I'm the person who are talking about harm reduction and doesn't write in the correct way harm reduction. As I said, no, harm reduction in Spain, it's very developed, especially in the Catalonia area. Catalonia is in the north of Spain. But, okay, we have a very good programs or services related with opioid intravenous use or with stimulants use, smoked also, but we have a different situation here. We are talking about oral, and we are talking about legal substances. So we run, no, vaya. Okay, we did a qualitative, descriptive and exploratory research. Here you can see the two routes, no, of migration, like Las Canary Islands and the Ceuta y Melilla. If you see the lines, and Catalonia is the red part. We ran 14 focus groups with people who is using substances, with harm reduction staff, with administration participate also. And we decided to do a specifically focus group with this young homelessness, with this topic, but also in all the rest of the focus groups, promote to talk about this population. And it was very interesting because in the specific focus group participate people from Canary, people from Ceuta y Melilla, people from Andalucía, es que esto lo guay, ¿no? People from here, people from here, people from here, people from here, and people from here, because the use of substances may sometimes start here or here, but the explosion of the use is here or here. So you have to understand the migratory journey to understand how people is using these substances. No, vaya. Okay. Well, the results. Mostly men, but well, no. This is the typical, I think, no. This is the typical image of this group, no? This population group. Always we are seeing men, but our first question was where are women? Where are LGBT people here? There's no people. Well, the results reported that the low representation, it's related with they are using another migratory circuits related with sexual and violent domestic migratory routes. Okay, the use of benzos and benzodiazepinas and gabapentina or pregabalina is related with the homelessness situation, of course, but also they are coping, no, the use of the young people, the Spanish young people, because everybody is using benzodiazepinas, not only this group. So they are coping this use because they want to, no, well, they want to be integrated in our community. Okay. Well, this is not. At the end, this is not recreational use. They are auto-medicalizing their own suffering. So you cannot understand. No, probably the people from Spain is using Ribotril or Lyrica to go to a party, but this group is using these substances as a strategy to deal with trauma and the trauma experience. Of course, the regular situation, no? The regular administrative situation, the illegal market, the big illegal market that we have with these substances, the difficulty to diagnosticize the mental health of this group, and of course they are living in the street. The risk of lethal overdose is very high. So maybe that's the point that harm reduction have to put the focus. And now we don't have harm reduction programs or services specific to this route and to these substances and to this group and to this nothing about this situation. And I think that's all.
Thank you, Esther. Any questions? Yeah.
Hello, my name is Magda. I'm from Portugal. In first place, I want to congratulate you for the bravery of exposing such a big gap that is the medicalization of the migrants and cope with trauma and the overprescription of meds that is happening, and to expose that we don't know how to deal with it, and there's a big gap in harm reduction for the excess of prescription of Rivotril, benzodiazepines like Lyrica, and so on. In Lisbon, where I work, I also see this flow of migrants, and I'm very happy to see someone actually saying, I don't know how to deal with it, and it's a fact. The major overdoses alarms we have, it's because of mixed Rivotril. And the thing, when you said you don't know, there's something I know that, for example, some doctors who don't have to put up with the clients, they prescribe 9 bottles, and they let them out of the hospital with 9 bottles of Rivotril, which is, I think, is pretty much like sending someone to suicide. And I think we should actually address this fact, because it's becoming like a snowball of violence among them, because of course someone with the 30 pills of Rivotril inside the organism, to be able to do the self-management of money, they do crimes, they do violence between each other, and I also don't know how to cope with it, and I see a rise of violence among the migrant community and abroad, and a turn aside of this fact. So congratulations.
Thank you.
Thank you for that.
Hi, I'm Barbara. I'm doing a street work in Vienna, and I'm very, it's very interesting to hear that you have the benzo problem as well, because in Austria and Vienna we have it quite the same for a long time with the local people, and now we see very young people on the streets, maybe with the same history coming from the Balkan route. Yeah. So it's the same story from the different side. And what happened in Austria a long time ago, I'm not a doctor, but we have special receipts where you have to prove by another municipal doctor also the benzodiazepines, and that kind of work for the local people, not for the black market, of course. There's still too many pills around and prescribed pills around for everybody, but I think that helped a little, to keep the numbers down, that you have a second doctor to approve every month. You get a monthly prescription, and then you have to go to another doctor to re-sign it or whatever, and that helped a little, I guess. But still, the black market is crazy. Yeah. And the people, I witnessed that myself, the people are getting younger and younger and younger. And the question I have is, do you kind of, what do you think as a start? The benzos are kind of a start into the whole drug scene, I say. The entering substance.
We have had benzos in the illegal market since I remember. I don't know, here is the Catalonia administration, public administration, but I think we have I'm 40, and I remember benzos all the time in the illegal market. But now I think the situation is different because we are over prescribing. I think Europe must to think what we are doing with medication, because in all the presentations we are talking about opioid crisis, the prevention of opioid crisis, but we have a benzo crisis and we are not doing anything. And
Hi Esther, I'm Amani, I'm a cultural mediator. I work for a project in Turin, Italy, and for many years we work with either legal or undocumented migrants. The young ones that come from the Moroccan route are with Rivotril and Lyrica. They already come because they use it in the country of origin. I wanted to ask you if in Spain you've also got tramadol as a problem.
Not now, not yet, but we love pharma, so probably, no, it's not common. It's maybe sometimes you can see, well, it's not common. It's not so common as benzos. We use it, of course, but not so habitual. Yeah, we found that people, as well, to answer you, to complement you, we found that people in the north, in Tanger, in Morocco, Tanger city, they are using Rivotril to do the jump, no, to arrive. So maybe the Rivotril use starts in their own country, but with the intention of use that in the migratory movement. So it's not.
That's when it becomes problematic.
Exactly.
But they already used it for recreation
Exactly.
purposes in the country of origin.
Exactly. Ya está.
I want to make a remark.
So we have 1 or 2 minutes, and then we have to
close.
Please.
Yeah.
Now, I'm not a psychiatrist. I think my colleague, which is a psychiatrist, might want to add on this one. I think the issue here is not about restricting the prescription, because the more red tape you add, I don't think you find any solution to that. I think the key is to think about what you said. The use is not recreational, is an attempt, a botched attempt at self-treatment. Now, you provide true treatment to these people that are traumatized as adolescents, and I think you will find that the market for all that benzo and pregabalin will be far, far lower. Okay, that's my opinion.
Thank you.
Yeah, it's on.
Thank you. Just a short question. I'm from Greece. In Greece, benzodiazepines are, again, a similar problem, is too much of a problem as well. Right.
You are in the middle, I'm
but,
sorry.
So, but my question is, I understand that in Spain, the problem is clonazepam. What about
and pregabalina?
And pregabalin. Okay.
Yeah.
And what about
the other one?
Flunitrazepam, like rohypnol.
Like rohypnol. We don't have.
No.
No.
Oh, that's good.
No.
Rohypnol, flunitrazepam.
We had problems
in Greece. That's the main benzodiazepine used in the street markets.
We don't have it.
What about quetiapine? Do they use quetiapine?
Quetiapine. It's not used in the legal market, and it's not used as a good pill to survive in a homelessness situation.
Mm-hmm.
Now, in the past 5 years ago, we had a lot of alprazolam in the illegal market. So, diazepam, of course. But now, no, the focus is in clonazepam and pregabalina. Yeah. Right. Quetiapine is not in the illegal market.
Right. Thank you.
Okay, so thank you so much. And time flies when you're having fun, right? But yes.
Just one last question, very quick.
Okay.
I just want to, to everyone of my colleagues here, I want to ask how peers are involved in your services or research, and how they are hired, formally hired. Peers.
Not in our service. There's no peers.
We have the option to ask clients to help daily with chores like cooking, cleaning the neighborhoods, picking up donations, these kind of things, and they get some money for it. Huh? Location council. Yeah, we also have a location council, a clients council, where clients can speak up about issues that they experience, policies that they would like to change, or you have the same? Yeah. Nice.
We don't have peers in living in the street. People who is living in the street is not peer. We have another type of peer. Maybe I'm a peer, but not living in the street.
Well, actually, they have, let's say, the position of informing and consulting on us, but no formal work relation.
Yes, thank you for this common question, and it was a very important one. Actually, we were talking about the topic yesterday in outreach work program session. There were a lot of talk about peer workers and how important they are in homelessness work as well. But anyway, me and Riikka would like to thank you all the speakers and audience for active participation and this interesting discussion around the combination of homelessness and harm reduction. And I think if you have anything you would like to ask, you can probably contact the speakers and us if needed. I guess I just want to say thank you everyone, and let's have some coffee next.